Okay, so we've been asked to put together a panel discussion on some interesting cases, but also some dilemmas. Okay, and that starts off with what you can see here, which is during sinus surgery. Okay, and it's the right sinus complex. So the orbit sits on the left side, and the middle turbinate sitting on the right side. And what the little dissector is pointing at is some dehiscent fat. Okay, so you've been dissecting away and have flicked away a little bit of lamina papyracea, and either your microdebrider has nicked it or your suction has just pulled out a little bit of fat. So, Louise, if you're there.
Yes, hi Raj.
Yeah, okay, hi. Does that cause you great consternation? Are you going to abandon your surgery?
So it's certainly not something that you would abandon your surgery for, but it's something that it's very important to identify, because, you know, whether or not the lamina has been dehiscent prior to you starting the surgery, there's obviously now a defect in your periorbita, and you want to stay well away from that area because you don't want any further complications. So I think identification of this is key.
And when you've exposed the tiger like that, do you keep poking it, keep sucking it, just to make sure, be absolutely sure, is that fat? Is it a polyp? Suck, suck, suck?
No. So what you want to do in this situation is stay well away from that. So I would aim to proceed with the case and to do so safely, but I would be staying well away from that area. You don't want to suck on it. You don't want to make the defect any bigger than it is. You know, once you've identified that, if you suspect that it's fat there, I would recommend that you take that at face value, you presume that it is fat, and that you stay away from that.
Okay, Sam, if you're there. How might you protect the area if you were thinking of proceeding with your surgery? Might you lay something over?
Yeah, so typically if this occurred during operation, I totally agree with Louise. This is not something that I would personally stop the operation on, unless of course there is other complications, like say uncontrollable bleed. But with some fat prolapsing into the nasal cavity, the last thing anyone wants to do really is keep poking at it or sucking at it, because the more suction on the fat, more prolapse occurs. So typically what I would do is cover that area with a neuropathy, and then continue with the operation. A neuropathy is normally soaked in adrenaline or diluted adrenaline, and so that there is no effect on orbital function, but so they carry on with the operation. There is no need to stop the operation.
Okay, all right. And I've heard in certain quarters that there's a concern about constricting the blood supply of that little nubbin of fat, and that you should make the opening wider. What's your view on that? Or poking the fat back?
I think, yeah, I heard that comment before, and I think that might be in relation to how much trauma there is to the fat itself. So obviously, if the fat is relatively atraumatic and it's not particularly bleeding, then I would think leaving it alone would be fine. But obviously, if the fat is you know, the surrounding vascularity of the fat is bleeding, then potentially that argument might hold true, that there is continued edema around that particular area, and that, you know, one need to do something, i.e. potentially looking at decompressing that area a little bit more. But certainly the number of cases that do occur like that are very, very small, and the evidence remains very, very anecdotal, I think.
Okay. Right, so the take-home message is that there's no need to abandon your surgery, but recognise that you've opened the medial orbital wall, and don't keep sucking on the fat. Yeah. I'm surprised none of you have said to me, what are you worried about, Raj? That's normal, right? That's what it always looks like. Any questions from the audience, Abby?
So I would like to just pull out from the poll. We had about 1 in 5 people saying that you might want to push the fat back. How would the panel feel about pushing the fat back?
Yeah. So as Sam just mentioned there, I think once you've recognised it, okay, the dangers of pushing fat back are that if you've traumatised the fat and it's bleeding, or if the medial rectus muscle is sitting very close to you, then you risk causing more injury. Okay, so the worst that could happen in that situation is that little bit of fat necroses, and it becomes involved in the re-epithelialized surface. So no, I certainly wouldn't advocate pushing it back.
Raj, can I just say something about the microdebrider? I've been involved in one situation where the microdebrider was sucking in fat, and the last thing anyone should be doing is pulling the microdebrider out the nose. So as soon as you recognize that the fat's kind of been sucked into the microdebrider, stop microdebriding, get your assistant or get your scrub nurse to occlude the suction, to reduce the amount of suction from the tip of the microdebrider. And then you need to slowly tease the end of the microdebrider off the fat, but do not pull the microdebrider out, because you will pull a lot of fat out as well.
That's a great tip. So microdebrider is very helpful, but you know, in the wrong place, it can cause a dramatic amount of injury very, very quickly. So that's a really nice tip there. Okay, let's move on to the second case. And Showkat, I'm going to ask you to have a look at this one. Okay, so during a sinus case and during a Draf III type of operation, but it could be, you know, it could be just a full house sinus case. It could be an ethmoidectomy. What's happened here?
So this is during a Draf III, and we can see the posterior wall of the left frontal sinus. There seems to be a small defect with CSF leakage. So we've got an iatrogenic CSF leak here, it would appear.
Okay, all right. And so the sorts of things going through your mind, okay, so extreme panic, okay, and then when you've composed yourself, what sorts of rational thoughts start to go through your mind?
Yeah, right. I'll just diverge for a minute. I mean, I've got a car with different modes. I don't know if I've talked to you about this before, and it's got a sport mode, economy mode, comfort mode. And as people, we need different modes. Sorry? As people, we need different modes. And as surgeons, we need different modes. So normally you're on cruise mode, aren't you? But when you have a big problem like this, you need action mode. And by that, what do I mean by that? What I mean is action mode doesn't go down the route of feeling sorry for yourself. Why me? Why today? Why is this happening? And sometimes I even see this, and people talk about this. You can even go into denial about this and just pack it and hope it goes away. But in action mode, you accept complications. As surgeons, if you're going to operate, you're going to get complications sooner or later. So you have to acknowledge the complication, and then you have to fix it.
Okay, all right, so you've acknowledged it. Okay, and you're not running away from the problem. Is this something that you try to repair at the same time if you have the skill? If you don't have the skill, what do you do?
Yeah, in general, I think if you've been trained to do an operation, you should train yourself to deal with the complications. So I would deal with this at the time.
Okay, all right. And Louise, what are your options for trying to repair this at the same time? Is there a role for just packing it, going away, coming back another day, or as Showkat says, is this something that really you should try to get someone in, if you can't do it yourself, to help you to do at that time?
Yeah, I agree with that. I think if you feel that you can't do it yourself, or you feel you need a bit of help, and just something that, you know, to bear in mind was going through my mind was, you know, certainly at the moment with doing these cases in full PPE, you know, by the time you get to this point, you probably are pretty tired. And so, you know, it would do no harm. There'd be no shame in asking somebody to come and give you a hand with this, even if it is something that you can normally do yourself. So I would definitely advocate to repair this at the same time. And, you know, you would be looking at this defect in particular, one of your issues is that your vascularized flaps are not going to reach this area. But it's a small defect, it's likely going to be low volume as well. And so I think in the first instance, you'd be thinking about harvesting some fat, and I would tend to go to the abdomen for that. And you'd want to use that either as you know, as an underlay, and then you could put some Tisseal or some Duraseal on top of that. Other options would be some fascia, so a small piece of fascia lata. You could use that in combination with your abdominal fat as well. And with that, and such a small defect, you probably want to be using a kind of gasket seal type repair. I think it'd be difficult to get the fascia as an underlay in that area.
Okay, but Louise, I'm really concerned because the patient's not consented for what you've just described.
Well, I think when we consent the patients, we should be, certainly for this type of surgery, should be explaining to them that CSF leak is a recognised complication of this surgery, and there is part of the consent form where, you really have to do what's in the patient's best interests, and, that would be preventing infection, meningitis, cerebritis, etc. And so really this would be in the patient's best interests. Again, though, if that was something you were concerned about, discussion with a colleague, maybe somebody more senior, a clinical lead or a clinical director would be, potentially just a phone call away. So, if you have any concerns about that, discuss it with your colleagues.
Okay, and it's an emergency procedure to try to correct a complication of surgery. So I think we'd all agree that that's a reasonable thing to do. Sam, so I've repaired it, okay? I've packed it. I just send the patient home. This was day case surgery.
No, I think in a situation like this, you will be explaining to the patient why the patient's got a slightly sore belly because of the fat, but also the rationale to keep the patient in for overnight observations, even if it was just as simple as 4-hour neuro-ops, but certainly keeping the patient in is a must. Because
any investigations that you might want in that immediate post-operative period?
Again, it depends on the intra-operative injury. I think if you were in any way concerned about an intracranial complication like a bleed, then certainly a CT scan would be called for. But if the skull base defect was as seen in the picture there, you could opt to keep the patient overnight under close observation and then review in the morning to decide whether or not you need to then consider cross-sectional imaging.
Okay, and you'd look to discharge this patient from your clinic as quickly as possible, wouldn't you?
Oh yeah, definitely, and refer it to my colleague 40 minutes east to you. Of course not. In reality, you obviously it will be full disclosure. You will have to explain what's gone on with the operation. Obviously, explaining that this is a recognized complication from sinus surgery, but you will be bringing the patient back several weeks after discharge to review, and even if you do undertake endoscopy at the time, say 2 to 3 weeks after, there might not be much to see because that entire area will be packed with nasal pore or a substitute like that. But it's certainly keeping very, very close contact with the patient to ensure that there is no additional unexpected sinonasal symptoms such as rhinorrhea, which probably may allude to a failure in that primary repair. So certainly patients need to be kept on a very close follow-up.
Okay. Any question from the chat?
One thing, just again from the poll, there was a pretty even split between choosing whether to do an onlay or an underlay. Is that an even choice, or would the panel prefer one approach?
Again, in the interests of time, I'll field the question. I think the larger the defect, the less effective an onlay repair would be. Okay, so I'd be looking for a multi-layer reconstruction, and then in that situation, I'd be looking for an inlay with an onlay. Okay. Thank you. Thanks, panel. Okay, Shahram, you're on.
All right.
Where are we? Okay, so what are we looking at here?
Yeah, obviously we've got a picture of a lady, I think for juniors who are going for the exam, possibly it's just like a spot diagnosis, inverted V deformity. And I don't know whether we can highlight it on them for them so that they know what we're talking about. And the reason they happen is because of the upper laterals sink in. And if they remember from the anatomy, they know that the upper laterals are attached to the septum and the nasal bone. So for them to go in, either their attachment to the septum is gone or to the bone is gone, or the attachment to the bone and septum is intact, and it's the bone and septum who have collapsed in. So
we're
yes.
just going to highlight the inverted V, so how it gets its name, okay? And before we go into a bit more detail about how it's caused and how it might be corrected, what are the sort of danger areas? So when we're doing septal surgery or septal rhinoplastic surgery, which areas? So you've highlighted obviously the upper lateral cartilages underneath the nasal bones there. What are the other areas that we really need to worry about?
Well,
Around?
Yeah, if we go step by step with all these areas, one is the attachment of the upper lateral with the septum. So if we divide it, again, it depends whether you're doing a just division. That alone, if you've kept the mucosa intact, doesn't cause a huge amount of collapse. Most of the time, even through endonasal, you can stitch it back to the septum. But if you're doing excision, especially when it happens when you're reducing the hump, you will lose that horizontal portion of the attachment between the upper lateral and the septum. And that, without any support, will collapse in. And to correct that one, you will put some sort of cartilage.
We'll come back to the correction. So anterior nasal spine.
So with regards to the bone, obviously, is with the plane of dissection. When you are dissecting, again, both endonasal or externally, but most of the time can happen through endonasal approach. When you're dissecting underneath this mat, going over the upper lateral, when you get to the bony junction, the upper lateral travels underneath the bone. If you continue in that direction, you will dislocate it from the bone. So you need to change the plane of dissection and become over the periosteum. So that's the connection with the, with regards to the septum, obviously, the septum.
I'll just jump in for a second, okay? So where the septal quadrangular cartilage attaches to the anterior nasal spine, okay? So at the columella-labial junction, and where your perpendicular plate of ethmoid and the quadrangular cartilage sit underneath the nasal dorsum. So those are areas where you need to be extremely careful when you're dissecting, because you can cause a little depression at the nasion, or you can cause quite a marked supratip saddle deformity if that posterior septal angle area becomes detached during surgery. So you have to be really, really cautious when you're operating in those areas. So Shahram, if you're, is that inverted V deformity easy to correct, or is it one of the rhinoplastic nightmares?
Well, it can be corrected, but obviously most of the time you might not see them immediately, so they will show up months down the line when everything is healed. It's going to cause disappointment for cosmetic patients because most of the effect is cosmetic. They will get some degree of functional effect as well, but they can be corrected, and there is a wide range of things, and depending on what the cause of this deformity has been, then you plan your surgery accordingly.
So you mentioned reboring and reattaching the upper laterals, perhaps with a suture. Okay, any other techniques?
Yeah, the other one is that, especially if you've had done a dehumping and you reduce that horizontal segment, you need to put some cartilage in, not only to support and bring that brow light reflex back and bring the dorsum, the width back. That usually is, especially for the exam, you call it a Schroeder graft, but there are a wide variety of them. You can use auto-Schroeder and so on.
What about crushed cartilage and fascia? Is there any role for that?
Yes, those camouflage techniques obviously can be used as well. However, if you've got some functional problem, just camouflaging is not going to sort it, so you need to structurally correct the deformity.
Okay, but these are bad deformities and best avoided if at all possible. Okay. Yeah. Any questions there, Abby?
So Raj, just a bit to clarify on the poll. Most people said when they get an anterior septal dislocation that they would try and anchor it to the spine again. You briefly comment on some techniques to secure it, or in what situations you might use a columella pocket?
Yeah, so as Paul said this morning, I don't find columella pockets useful. Okay, so there is nothing really of any strength between the medial crura to hinge the caudal septum and stabilize it within that pocket. Okay, So the first step of relocating the quadrangular cartilage to the anterior nasal spine is making sure that it's perfectly straight, okay? So any tension on it from the bones behind, or if you have a curved, bent septum, that's going to come back off the spine. It has memory, okay? So the work that you do has to be to straighten the spine. And then once you've straightened the spine, you know, you hear people talking about drilling a hole through the anterior nasal spine. You hear people using needles to bore a hole. Actually, it's sort of mushroom shaped, the anterior spine, okay? So in a caudal cephalic direction, if you use your forovicular rapide, then you pick up the cartilage that sits in that mushroom dome, okay? So it's very easy to stabilize your quadrangular cartilage within that anterior nasal spine without doing anything too heroic. So the tips are straighten the cartilage, make sure it's straight under no tension, and then put a suture in to stabilize it to the anterior spine. Okay? Okay, all right. So Showkat. This is a case of a septoplasty. So we're not going to talk about the longer term management of a nasal septal perforation, but this is a septoplasty that is going pear-shaped, okay? And two scenarios that I want you to allude to is where this perforation is, an anterior-based perforation, and how you would manage this situation intraoperatively, and something further back in the nose.
So prevention is better than cure. So I'll just briefly talk about prevention. I tend to prevent perforations by using a hemitransfixion incision rather than Achillians. I find Achillians can often tear, and then you're up against it. I tend to get a preoperative CT scan. I find that helps my planning, and it helps me identify beforehand the difficult cases. I use an endoscope. I think your rate
CT scan before all of your septoplasties.
Not all. It depends on the actual deformity. But if it's a difficult septoplasty, I do a CT scan. In fact, I have quite a low threshold for doing a CT scan. I find it helps in a number of ways, not just of the septum. But you're here. You've got a perforation on one side, and now you're up against it. The pressure's on a little bit. What you don't want is a perforation. So you don't want to tear on the other side of the septum in a similar position. So you have to ask yourself, do you feel confident in that situation to raise the flap on the other side, if needs be in this case? What you might find with some septums is you just need one main flap, and then you address the septum. So you leave the contralateral mucosa undisturbed, and then you can carry on doing your procedure. But if you need to do bilateral flaps in this situation to get a good result, you have to ask yourself, are you confident to raise the other flap without causing a tear? And if you are, then carry on. If you're concerned, you may have to call it a day.
Is it better to leave a slightly deviated septum than to cause a
through? Yeah, you can always come back another day, but if you probably don't want to come back because you caused a tear on one side, so the chances are it's a difficult septum. But you can employ other techniques. You could try and fracture that septum by just manipulating the side that has a tear. So if the deviation is on that side, you could do what I call a neurosurgical septoplasty. So they put an instrument in like Achillians and they fracture the septum, and that can address some of the deformity of the septum. The other thing you can do is address the turbinates. So you may have some residual deviation of the septum, but if you address the turbinates, do a turbinoplasty, you may find they have an adequate airway and an adequate outcome.
Okay, and what if that perforation is slightly further back in the nose? Does that cause you less concern than if it was anterior?
Posterior perforations tend to be asymptomatic, I find, so they don't concern me as much.
Shahram, so you've attempted to repair that. Splints always make you feel very good because they hide the problem. What would you do? Would you quilt? Would you splint? Would you do nothing? Would you pack?
Yeah, I usually put a piece of cartilage intervening between both sides, especially if there's another perforation on the other side. So I will quilt them a couple of stitches, but I'll put a splint as well. I think a splint gives me a little bit of relief, and also even if the patient is nosy, trying to do any fiddling with the area, that keeps the area intact. And for perforation, I'll keep them up for a couple of weeks.
Okay. Abby, Miran, any questions there? No? Okay, great.
There's none on the chat.
Louise, if you're there, please. What's going on this guy's nasal tip?
So you can see he's got an abnormal lesion on the tip of his nose. So you'd want to really be assessing this to try and get a diagnosis so that you can work out what your management's going to be going forward. So having a look at that, you know, I think your main diagnosis would be most likely BCC, but you'd also want to exclude an SCC. And so when I approach these, I tend to try and get a diagnosis sooner rather than later. So you want to probably take a biopsy in the clinic if you can, under a bit of local anaesthetic. So you could approach that either with a punch biopsy. You'd get a small kind of 4mm slither of tissue with that. You could use biopsy forceps if you don't have access to your punch biopsy.
Which bit of the lesion, Louise, is best to try the central area or at the margins? Which is the best area generally?
I think, you know, I tend to try and get it where you've got a wee bit of the normal tissue, so you've got the margin, but also a representative biopsy, because that will then allow you, if it's an alternate diagnosis, to allow you to make a diagnosis from that point of view if there's some normal tissue as well. If you're from the central part of it, you might get a better idea of a depth of the lesion. However, if you're wanting to achieve that, you're probably better going for a slightly bigger biopsy and using maybe like a wedge biopsy rather than a punch biopsy.
And let's say that your biopsy confirms that this is a BCC. Okay, what are your options then for excising that lesion?
So your options then will very much depend on your own department. So you can either plan to excise and reconstruct yourself, or if, for example, you had a Mohs surgeon in the department, then this would be a perfect situation. It's in a high risk area. You want to conserve as much normal tissue that's not involved. So if that was the case, then it would likely be discussed at one of the skin MDTs. When they're looking at the pathology, certainly normally just looking at vertical sections, they can actually miss over 60% of the margins there. And I think that probably accounts for these ones where you think you've had a full excision, but then they recur later down the line. So obviously the advantage of the Mohs is that they're marking out the lesion, they're tattooing it or marking it into different segments. It then is resected at a 45-degree angle, and it's looked at in real time by the operating surgeon with a microscope. So they can basically remove the tumour, make sure that they've got clear margins, but they're keeping as much normal tissue so that your reconstruction is as little an area as possible.
Okay, all right. So, Shahram, so this gentleman went via the skin MDT and the Mohs surgeon, and this is the defect, quite conservative for Mohs surgeons, but this is the defect that arose. Okay, so what are your options? And when you talk about your options, could you please allude to the nasal subunits?
Okay, so with regards to planning the surgery, obviously, with regards to the repair, we've got multiple options. Things to consider: one is the patient's aspects, which will impact what kind of operation we do. And also, for example, if the patient, whether they want to do it on the local or general, what are the patient morbidities, whether they are in the anticoagulation, and so on. But coming to the technical aspects of it, especially for the guys going for the exam, they need to think about the reconstructive ladder. So you would think, can I close this directly? Well, it's not going to be possible because it's going to cause quite a lot of deformity. Can I leave it for secondary intention? Yes, you can, because it's got a base, it's going to heal, it's going to be very deformed and depressed and full of big scar, but that might be what the patient needs or wants. So that's another option. You can put a skin graft. The skin graft you can get it depending on the size. This is a little bit big, but depending on how much skin you've got, you can get it from preauricular, postauricular, supraclavicular. Skin graft doesn't give you that convexity. It's, the shape, the color and texture of the skin is different. It will look like a patch when it's healed, but it's a simple operation relatively, and that might suit the patient. The third option then obviously is about local flaps. And there are a variety of them you can use it. So for example, you can use the bilobe flap as shown here, and you use whatever skin is available on the skin, try to cover that area. Again, you can use advancement flap, rotation flap. So these are the local flaps you can use. And then obviously you close them. There is going to be always scars here that are going through subunits that are not acceptable, but on balance of things, this might result in a very good result, one-stage operation under local anesthetic. Obviously, you're not following subunits of the nose. Subunits of the nose is essentially the lines for the shadows and highs and lows of the shadows that you see on the nose. And if you keep your reconstruction in those areas, you will get better results, okay?
So although, Shahram, although it's a much larger operation, if you were excising that entire nasal tip subunit, what might be a good operation, even though it's a larger operation, in terms of colour match for skin and repair?
Well, definitely flap is better than a skin graft. But if you want to now talk about the whole subunit of the, for example, tip, that's going to be too big for any local flap. Then we have to think about the regional flaps. And usually the workhorse for the nasal reconstruction is the forehead flap, which is, again, different kinds of forehead flap. Nowadays, most people use a paramedian forehead flap.
And this is based on which blood vessels?
Well, the supratrochlear artery is in there, but there are so many vessels in there that essentially it's not just supratrochlear.
How do you mark out the artery or the neurovascular bundle?
Yeah, there are, again, I use a Doppler just to check, but even I've had cases, badly smokers, that I can't hear it. I still cut it open. You will always find it the medial side of the eyebrow, okay? Or you can measure it 1.5 to 2 centimeters from midline, but it's always there. And if you can't hear it and if you don't find it, you will not cause much of a problem, especially if your flap is not too thin or too long.
And what's this showing?
Then this is at the end of the first stage, that the flap has been inserted onto the tip and some dressing in there, and the forehead has been closed. And leave this one on average about 3 weeks. If they're badly a smoker or they've got Raynaud's disease or anything, you might want to keep them longer. And then you divide them, and this one is about 2 months after the operation. As you can see, the forehead heals beautifully, so it doesn't cause much of a problem.
Abby, Miran, any questions there?
Just one question, Raj, just regarding if you were, I know we talked about kind of punch biopsy or excising, if you were just going to do a primary excision, would you close it at the same time, or would you delay the closure and wait for the histology?
Sharon?
Well, it depends. Obviously, the skin cancer is so common that you cannot really afford to wait and do a second stage operation for every case. Otherwise, the whole theaters are going to be full of skin cases. Most of them are well defined. You take a 4 or 5 millimeter margin and you got a clearance of a 95%. So majority of the time, I'll take them out and repair at the same time. I accept that it's going to be a few cases that might need to come back. But if I'm not sure, I will bring them and repair them as a second stage. But obviously cases for infiltrative BCC or morphaic BCC, they usually get Mohs. So when they come for reconstruction, you know that they have been cleared.
Okay. Richard,
thank you.
I'm very conscious of time, but are you happy for us to run over for 10 or 15 minutes?
Yeah, I think one more. Do you want to do one more case, Raj?
Yeah, very happy to do that. Okay.
Okay.
So if I'll skip over the other nasal reconstruction case. Okay, so Showkat, I'm doing a sinus case, okay, and I've been operating around the anterior ethmoid and up towards the frontal recess, okay, and all of a sudden my fellow shouts, screams at me, says there's a problem with the left eye. What have I done?
So this is one of your nightmares as a rhinologist, getting an intra-orbital hematoma. I've never come across a case myself. I've been involved in some cases from a medical legal point of view, and it's interesting. We're classically told that it's an anterior ethmoidal artery injury that causes an intra-orbital hematoma, but in the cases I've been involved in, it was actually after a middle meatal antrostomy that the patient got the hematoma. So to the trainees, I'd be very worried about doing middle meatal antrostomies in certain cases. And by that, I mean, scrutinize the scans preoperatively. I often find complications occur because something on the radiology is not being appreciated. So if the uncinate is very close to the orbital wall, be very wary. I would recommend the swing door technique rather than the incising the uncinate technique. But once you've got this intra-orbital hematoma, what do you do? Well, now, Raj, this is what action mode isn't enough. You need crisis mode now, okay? And by that, I mean, you're up against a deadline here.
Right. I'm going to describe then two scenarios to you, okay? One, where you're operating, patient is tubed on the operating table. The other is where the patient's awake in recovery.
Okay, so during the operation, if you come across this,
you talk about the on-table situation.
On-table, okay. So if whilst doing the operation, you find you get this intraorbital hematoma, I would do a decompression. Okay, you've got to do something to take the pressure off that eye, or they'll go permanently blind.
You've done the ethmoidectomy already, haven't you?
So if you've done the ethmoidectomy already, hopefully you've got the lamina exposed. You remove the lamina, you decompress the orbit.
Okay. Is there a role for a canthotomy and cantholysis?
Yeah, this is an interesting one because my understanding it was always that is to buy you the time. If you need to buy time, let's say post-operatively they have this hematoma and it's noticed post-operatively, the canthotomy is to buy you time to do the orbital decompression. Whereas some advocate canthotomy may be enough. So it'll be interesting to see what the panel thinks about that. Is a canthotomy enough, or do you have to then subsequently go on to doing a formal decompressive?
Louise, if you just comment on that, and then I'll take you into the recovery situation. Okay,
Yes.
so comment on the canthotomy, cantholysis.
If again, I've not been in this situation in a real life scenario, but I have thought about what I would do if it did arise, and I would proceed and I would do an orbital decompression as well, absolutely. Even if the patient had been background to recovery, you'd done your emergency lateral canthotomy, I would then get them background to theatre and perform that.
Yeah, and I think just in addition to that, just by, gently blotting the eye, if you still feel that there's tension there compared to the opposite side, compared to the side that isn't, I do a canthotomy and cantholysis.
Yes.
There is no disadvantage to doing it.
Absolutely.
Okay, so Louise, the situation in recovery then, or on the ward where the patient's awake but coughs all of it, and boom, this happens.
Yes, you need to act very quickly. I think if you can, for the patient, if they're awake, it would be nice to put a small amount of local anaesthetic in, if you can, just be obviously around the lateral canthus, just towards the orbit, without obviously going into the orbit, just to the skin. However, if that was going to cause any delay, then I would probably proceed without that. And you're really wanting to go down, you go really between the orbit and the bone, the orbital rim, and you can go down and you can use a hemostat in the first instance just to compress it for about a minute, just to minimise bleeding, or you can just go down with your iris scissors, and you really want to go down through all layers of the tissue. And then after that, it's very important that you pull, as you can see there in the video, you're pulling that lower eyelid forward so that you cut through then your lateral canthal ligament, and it's important not to forget to do that.
Okay, and then you take the patient back to theatre then to decompress the medial orbit. Okay.
I would, yes.
Any medications that might help to reduce the orbital volume and pressures?
Yeah, I mean, you could consider things like IV mannitol and things, but I think by that point you probably would be discussing it with your ophthalmologists as well and taking any advice. I'm not really sure.
Or Diamox, an intravenous dose might help you, but then yes, you'd be seeking the advice of your ophthalmologist as well. Okay. All right. Any questions on the poll? Mirza, Abby? Okay.
Yeah, no, I think it just confirmed what the panel had said. Really, I think everyone was on board with that.
So again, in the interests of time, I'm very grateful to the panel for the expert and wide opinion, but I think there's a consensus there as well, which is very nice. So we've had no sort of great dissenters. Even Showkat's behaved and kept to the party line. Okay, Richard.
Yes, and that was brilliant. I'd just like to thank all of the panel for your time. I know the candidates will have found that very useful.